First, I'd like to thank the Trauma Committee for the opportunity to present this work effort looking at trauma-induced coagulopathy and massive transfusion in pediatric trauma. So this was a joint effort that came out of the Guidelines Committee for the Pediatric Trauma Society and the Eastern Association for the Surgery of Trauma. So we know from a litany of adult and pediatric studies that the more severely injured you are, the more coagulopathic you are, and the more likely you are to die. And we know these relationships hold true whether or not the coagulopathy is assessed with conventional coagulation tests or viscoelastic monitoring like TEG and ROTEM. The purpose of this effort was to provide some evidence-based, specifically using grade methodology, behind some recommendations specifically looking at the role of viscoelastic monitoring, blood product transfusion ratio, as well as massive transfusion protocols in the management of severely injured children. We came up with 4 PICO questions, and the outcome for all of these questions were the same. So they were mortality, total blood products transfused, ICU-free days, and vent-free days. Just some general observations about what we encountered as we embarked upon this effort. So first of all, there were very few studies that made our inclusion criteria. The vast majority, in fact, all of them were either retrospective or prospective observational, and the overall quality of the evidence was low or very low. Because of the nature of the studies, we could only do qualitative synthesis, not quantitative synthesis. So we chose to incorporate and reference high-quality adult literature and guidelines to help guide our recommendations. So let's get into it. So the first question that we asked was, in severely injured children, are initial viscoelastic abnormalities, so TEG and ROTEM, better than initial conventional coagulation test abnormalities for predicting trauma-induced coagulopathy? We started off with 603 abstracts that met the criteria, but actually identified only 1 study that we were able to include in our analysis. This was a retrospective single-center study of 87 patients. Overall, it was a very low quality due to the nature of the study. The authors did look at mortality, total blood products used, and ICU-free days. And overall, when you take a deep look into their data and their correlations, the viscoelastic monitoring parameters in this study, it was a rapid TEG, had a better correlation with outcomes, things like mortality, blood products transfused, and also life-saving interventions. We therefore concluded from that study, but also again, multiple high-quality adult studies, for a conditional recommendation that viscoelastic testing be considered the better study for predicting trauma-induced coagulopathy in pediatric trauma patients. Our second PICO question really tried to get to the heart of how best to direct a goal-directed hemostatic resuscitated effort in children. Specifically, is a goal-directed hemostatic resuscitation using viscoelastic monitoring compared to conventional testing result in improved outcomes? So of the almost 600 studies that we identified by abstract, we only were able to include 5. So these were retrospective and prospective observational studies, very low quality evidence. There are 5 that looked at mortality, 4 studies that looked at total blood products used, and 2 studies that looked at ICU-free days and vent-free days, respectively. The problem we encountered was that there were no studies that allowed for a direct comparison of viscoelastic monitoring versus conventional testing. So again, we had to rely upon our adult studies to help guide our recommendation. So our recommendation was, again, a conditional recommendation that viscoelastic testing be used to guide goal-directed hemostatic resuscitation in pediatric trauma. The overall quality evidence was very, very poor. But when we looked at the adult literature, as well as the extremely favorable risk-benefit profile of viscoelastic monitoring in the adult study, we felt it would be most appropriate to use viscoelastic monitoring in this setting. The third PICO question really tried to get to the heart of the ratio. So how do we best resuscitate these patients? Which products and at what ratio should we administer them? And the PICO question at hand was, does a high ratio or balanced ratio of plasma and platelets to red blood cells compared to a low ratio or unbalanced ratio of plasma and platelets to red blood cells result in improved outcomes? Of the almost 1,500 studies that we identified, we were able to find 7 that we were able to include in our analysis. Again, very low quality evidence, mostly retrospective and prospective studies, but there were some of the data that lend themselves to a more visual presentation. So This is a study from 2017. This is a retrospective review of the Department of Defense data set looking at plasma red cell ratio and mortality. And they actually found that a more balanced resuscitation and the nature of it didn't actually impact mortality. There was a study that came out of from 2019. This is from TQIP data, looking at both plasma to red cells and platelets to red cells, and they actually found a survival benefit both in 4-hour and 24 hours for the more balanced high ratios. And then finally, there was a more recent study done by the Atomic Group looking at 100 patients that were massively transfused, and they also found a clear survival benefit to a more balanced 1-to-1 ratio of red cells to plasma. So we then conditionally recommend that a high or balanced plasma to red cell ratio be administered during resuscitation of critically ill children. There was not enough data to make a recommendation specifically related to platelet to red cell ratio. It was very challenging when looking at these studies to make that recommendation. But again, the limited data that we have in children and the high quality data that we have in adults really makes us make that conditional recommendation for a more balanced approach. Our final question that looked at was specifically related to massive transfusion protocols. The question was, in pediatric trauma patients with trauma-induced coagulopathy, does MTP activation improve outcomes? And again, very low quality evidence. Of about 1,500 abstracts that we reviewed, were only to include 3 studies. The 3 studies looked at mortality and total blood products use. Overall, the impact of massive transfusion, we weren't really able to show in children that there was a clear survival benefit. Those studies that looked at massive transfusion, children clearly get products sooner. They're able to get more balanced ratio resuscitation sooner. And it is thought that that would have a favorable outcome on mortality. However, again, in the adult literature, there are clear survival benefits to having massive transfusion protocols in place. Based on the totality of the evidence that we had, we conditionally recommend that massive transfusion protocols be used to facilitate the resuscitation of coagulopathic pediatric trauma patients. Conditional recommendations in summary would be for the use of viscoelastic monitoring, TEG or ROTEM in the trauma bay, both to identify trauma-induced coagulopathy and also to direct goal-directed hemostatic resuscitation. That resuscitation effort should be in a balanced ratio, particularly for plasma to red cells. And finally, there is definitely a role and recommendation to have massive transfusion protocols in the resuscitation of these children. Thank you.